Welcome to the Stanford Women's Health Vodcast series. I'm Dr. Sharon Hung, Director of Women's Health for the Primary Care and Population Health Department at Stanford. From debunking myths to exploring the latest research, we will delve into the world of women's health with leading experts in the field. Today, I have the pleasure of speaking with Dr. Sun Kim. She's an associate professor of medicine and endocrinology at Stanford Medicine. Dr. Kim specializes in the treatment of type 2 diabetes, obesity, and polycystic ovarian syndrome. She's especially dedicated to helping individuals in transforming their lifestyles and improving their long-term health. Additionally, Dr. Kim collaborates closely with the reproductive endocrinology team to support women in enhancing their health, losing weight, and optimizing their chances of successful pregnancy. Dr. Kim, thank you so much for being here today.
Oh, thanks so much for having me.
I wanted to start by asking what motivated you to specialize in endocrinology and more specifically polycystic ovarian syndrome?
Yes, so I don't know about you, but when I was deciding on a specialty, I sort of had a hard time deciding between actually OB/GYN and internal medicine. And so I was excited to be able to specialize in endocrinology, where I can also still work with women during their, reproductive times. And one thing I really loved about OB was that it's kind of a rare time in medicine where you see people during a very happy time. And the things that I appreciate about working with women with polycystic ovarian syndrome is sometimes the journey to conceiving and having a child is so hard earned. And I really loved, going through that journey with them. The other thing about specifically choosing endocrinology is right after like medicine residency, I worked a bit as a hospitalist. And I remember really being fascinated with type 2 diabetes because, as you know, in the hospital, many of the patients have comorbid type 2 diabetes. And I was in the area because my husband was doing a fellowship. And I happened to reach out to Gerald Reben. I don't know if you remember him, but he passed away and he was at Stanford for a long time and he was my mentor and he coined the syndrome X, and he just was a brilliant person and he made many connections between insulin resistance and metabolic disorders, which I think is very important for women with polycystic ovarian syndrome and their physiology. So that was a really long-winded answer, but that's how I got here.
Yeah, no, I mean, that's so interesting because there is so much of that fertility issue in PCOS, and it's such a heterogeneous disease that it's often co-managed by all these specialists that you had interested in the past.
Yeah.
And we'll talk a lot about insulin resistance, so I'm glad you brought that up.
Okay, great.
But let's start by defining PCOS and why it's such an important women's health issue.
Yes. So I think there's a lot of confusion. Just to start off, so PCOS stands, as you know, for polycystic ovarian syndrome. And it's the most common endocrine disorder, especially in reproductive age women. And the numbers vary because we're not systematically evaluating all women, but at least 10% of women. So a lot of women have polycystic ovarian syndrome. And then this is sort of technical, but in the medical literature, it's often thought of as a disorder with ovulatory dysfunction. So you're not ovulating regularly. And also like a hormonal disorder where you have hyperandrogenism. And then there's also ovarian findings. I would say, like on the medicine side, we tend to focus more on the ovulatory dysfunction and the hyperandrogenism, whereas I think the gyne counterparts like to also look at the polycystic ovarian morphology, probably because we're not doing the ultrasounds, but I think it is an important component as well. I think from the patient perspective, they come to medical attention more for the irregular menstrual cycle. And I know we'll get into it, but symptoms of extra hair growth on the face and body, is another, important way patients come to medical attention and get diagnosed with polycystic ovarian syndrome.
Okay. And then my understanding, I know you mentioned elevated androgens playing a role. We've talked about insulin resistance, and I kind of know those two terms in conjunction with PCOS, but what else do we currently know about the underlying pathophysiology of the
Yeah,
syndrome?
I wish we knew more. We know a lot, but I think we could still do more to uncover the underlying physiology of polycystic ovarian syndrome. What we understand is that there is a dysfunction in the connection between probably the hypothalamus, the pituitary, as well as the ovary axis. And my husband hates it when I talk about endocrine, axes and feedbacks, even though he's a nephrologist. But I think it's a good way to think about the connection between the different organs in our body. So the hypothalamus makes an important hormone called GnRH. And, you know, I we don't often think about this, but hormones are secreted in sort of this pulsatile form. It's not just like on and off. And the pulsatility of GnRH seems to be increased in women with polycystic ovarian syndrome. And then that leads to another gonadotropin called LH being increased in its secretion. And LH feeds back on the ovaries to make more testosterone. In addition, this host of sort of kind of disordered hormones can also lead to kind of arrested or altered development of follicles in the ovaries. So normally in women in reproductive age times, you have a dominant follicle that lets out an egg. And so it kind of starts the menstrual cycle. But that process is disordered for women with polycystic ovarian syndrome. So you have these follicles trying to develop, but they sort of get arrested in a smaller stage. And so I think that leads to a lot of hormonal changes. And the ultimate result is increased androgen secretion. And we think about androgens as like these male hormones, but as you and I both know, men and women both have these androgens. They're just higher than other women without polycystic ovarian syndrome. And then, I brought up insulin resistance before, but I know we'll delve more into it. But in insulin resistance, you tend to make more insulin. And then the higher insulin level also feeds back on this hypothalamic, pituitary ovarian axis to enhance testosterone secretion. So it's almost acting as a co-activator to enhance testosterone secretion. So those are kind of the two common abnormalities in polycystic ovarian syndrome. I would say patients have more control in controlling the insulin resistance. And so I think that's why we focus more of the interventions on that aspect. But I hope in the future we can also modulate the hypothalamic pituitary ovarian axis through other medical interventions.
Yeah, that's interesting. I think I didn't realize that insulin could act as a kind of co-activator in the hypothalamus pituitary axis.
Yeah.
So you mentioned earlier that there's about a 10% prevalence of PCOS, which I find surprising because I don't feel like I have 10% on my panel. I'm sure I'm underdiagnosing a lot of cases, and I hear it's underdiagnosed in general, probably largely because everyone presents so differently. So I'm curious what you think are maybe some symptoms or presentations that, we might miss that are actually PCOS patients.
So the interesting thing about the literature surrounding polycystic ovarian syndrome is that we are not trying to do case finding in the general population usually. And so all of the literature really comes from referral centers. Like, for instance, I see a lot of new patients with polycystic ovarian syndrome. But if I characterize the patients seen in my clinic, they may look differently compared to sort of the general population of women because, we're obviously a referral center and there are certain um, patient populations that are drawn to coming to Stanford, for example. So But to your point, I do think people are underdiagnosed. A lot of the women I see, and this is also written about in the literature, see several physicians. They see, primary care, family medicine, gynecology, OB, naturopath, and then finally they make it to me to sort of firm up the diagnoses. And I think there are several reasons for this. First, sometimes when the diagnoses require sort of a comprehensive evaluation of a person, and then you have to decide, oh, they need to meet certain criteria to qualify. It does create somewhat of a barrier to really getting a firm diagnosis. I think many physicians might say, oh, it looks like you may have polycystic syndrome. I'm not certain, but you may have it. And so that leaves the patients feeling, unsure themselves, even though the physician probably felt that it was likely. Also, I think women's health in general is under study. And when women present with irregular menstrual cycles, which is probably a common way women present, I think the inclination for us is just to say, okay, let's just put you on birth control. And then, when you're ready to have kids, let's reevaluate that. And so we're in some ways putting a Band-Aid on it instead of fully, discussing it. And so I think we need to study it more. We need to put more attention on it. And I do think I heard this a long time ago in my training where, menstrual cycle is like the extra vital sign. And so I do think it's really important. I think we need to have that message for women starting, at time of menarche to say, it's really important for you to keep track of your menstrual cycles. And if you are not having regular menstrual cycles, there might be something going on and we need to evaluate it. I do even have a lot of younger women say, oh yeah, it was irregular, but I didn't really think about it too much until, 5-10 years later. And so I think really, looking at the symptoms, I think one is the menstrual cycle. And then maybe, this might be a good time to go through the criteria and see how we can identify patients.
Yeah, absolutely. I love how you mentioned the period being a vital sign. One of the gynecologists I interviewed earlier had mentioned that as well. And at first I was like, oh, okay, that sounds funny. We don't need another vital sign.
Yeah.
But I've learned so much adding that into my questions recently. So I definitely think that's a good one, just to ask people how their menstrual cycles are.
It's so interesting because, a lot of progress notes sometimes have that last menstrual period as a fill-in, but a lot of times it's left blank. So I don't, because we have so much to cover. And I know in primary care, there are so many things to cover. And so sometimes, that is not covered. But I think it's also important for women to get the message that, it is important for them. I have a teenage daughter, and when I ask her, she says, I don't know, mom. And I keep trying to tell her, no, honey, it's very important. So I hope she gets the message. So, in terms of the criteria, and so I think this is another reason because like there have been different consensus guidelines that have promoted different criteria for polycystic ovarian syndrome. But I think everyone sort of settled on what we call the Rotterdam criteria. And it was set forth in 2003 and it has been updated. But it's sort of the broadest and captures, I think, more women. So there's 3 criteria and you only need to meet 2 out of 3 criteria. So we can go through maybe each individual criteria. One reflects the ovulatory dysfunction that I mentioned. That means that you're not regularly ovulating. And so women will present with irregular menstrual cycles. And that could mean that menstrual cycles are longer. I always tell women and also, trainees, think of the first day of the menstrual bleeding to the next first day, that's, one cycle. And that can be, I know we always get taught, and a lot of my patients think, oh, it has to be 28 days, like this perfect 28 days. But, it can range. And we consider prolonged being greater than 35 days. But some women, it can be short, and they can have more frequent menstrual bleeding, less than 21 days. But I would say most women with polycystic ovarian syndrome, when they present, they'll say, oh, I just, miss, bleeding, once or twice a month. And if you haven't had bleeding for over 90 days, that's also called, irregular menstrual cycle. So that's one, ovulatory dysfunction presenting as irregular menstrual cycles. And two is either symptoms or biochemical evidence of hyperandrogenism. So some ways women present with hyperandrogenism is that you can have extra hair growth that we were talking about. Especially a lot of women are uncomfortable with the extra chin hair growth because that's obviously visible. But I think some women with polycystic ovarian syndrome really embrace it, and they're okay with the look. But that's one, hirsutism. And we can talk about other body parts, but is the chin and the body hirsutism. You can't have acne, but acne, can be non-specific, and then acne is very common during the adolescence. And then third is hair loss. That's also very non-specific. And the way we think about hair loss is in the literature, some people talk about male pattern balding or, female pattern balding. And it's surprising, but it's more this female pattern, even though there's more androgen. So we may think it looks more like male pattern, but it's more looks like female pattern, meaning there's kind of a lot. I hope I don't have a loss of density, but you can have loss of density, especially at the top here. As you know, male pattern, you tend to recede up above, and then there's kind of at the vertex up here, a loss of hair growth. And we sometimes do see that when the androgen levels are very high. But in polycystic ovarian syndrome, I tend to see more of this female pattern hair loss. And there's different ways to grade it, and there's different scales to use. But so that's some of the clinical manifestations. So extra hair growth, acne, hair loss. And then, there's also biochemical evidence, like we can check, testosterone. So I tend to check testosterone and free testosterone. I'm probably not very parsimonious in my ordering because sometimes, I don't want to bring people back for extra labs. So I tend to do a couple others, but we, maybe you could talk about that later. And then the third criteria is having polycystic ovarian morphology based on pelvic ultrasound. Now, the things that we're looking for are that the ovaries are enlarged or that they have increased number of the smaller follicles. Remember how I was saying in polycystic ovarian syndrome, there's sort of a disruption of developing a dominant follicle that releases the egg. So there's a lot of these 2 to 9 millimeter follicles. And the criteria got amended because our ultrasound techniques are so much better. So before it used to be a smaller number, now we say 20 or greater. But unfortunately, I would say a lot of radiologists that say a lot of follicles consistent with polycystic ovarian disease. But I would love in the future to have better clarity on radiologists being able to give us more of a quantitative number. But I can imagine spending time to count each one, may also be tedious. So just to recap, so ovulatory dysfunction presenting as irregular menstrual cycles, hyperandrogenism, either clinically or biochemically, or polycystic ovarian morphology, you only need 2 out of 3 of these criteria. The new update, I love when there's a new update in polycystic ovarian syndrome, but there was a guideline in 2023 suggesting we can use a hormone called anti-Müllerian hormone, or AMH. And I have been already using this, so I was happy to see that people are thinking now that we can use it to assess women with polycystic ovarian syndrome. Gosh, I feel like I'm talking a lot, but just to explain the AMH, those small follicles in the ovaries, they're the ones that make AMH. So the AMH level tends to correlate with the number of the follicles. So the new guidelines suggest you can either do AMH or you can do the ultrasound. You don't need both. And also the thing to note is if you already meet two criteria, the number one and two I mentioned, you don't even need to do the ultrasound or the AMH. I think by the time people see me, I like to do more rather than less. But I try to tell patients, not everyone, you don't need all this. You already have the diagnosis.
Yeah, yeah. Thank you for going over the criteria. So I have some follow-up questions about a number of things that you mentioned. So I know the ultrasound is not necessary if they've already met two of the other two criteria of irregular periods and signs of hyperandrogenism. But if the ultrasound is ordered, does it matter what type, like where they are in the cycle? Does it matter if they're on birth control?
Yeah, I mean, great questions. As you know, sometimes when we order ultrasound, it depends on the schedule, right, of radiology.
Yeah.
And so unless I really need it for a specific reason, I don't have um, my women time it to their cycle. But I think it's really helpful to know when in their cycle they had the ultrasound, because the thickness of the endometrium can depend on what part of the cycle, like whether it's follicular when they're developing the lining, or if it's after menstrual bleeding. Oh, I mean, follicular is when they're developing, and then if you go to luteal, that would be at the thickest right before they have the menstrual bleed. But right after menstrual bleed, the lining may be the thinnest. And so sometimes if we're trying to understand the lining, which has nothing to do with the PCOS criteria, but sometimes women with polycystic ovarian syndrome, they haven't had menstrual bleeding for several months, and we worry about building the lining in the uterus. And so for me, sometimes if I need to know that, then the timing matters. And in the guidelines, it suggests that when you get a pelvic ultrasound, that they note when the last menstrual period is. And so I think that would be really helpful for this type of assessment. And also, sometimes even when we're evaluating someone with ovulatory dysfunction, they may develop this dominant follicle. And then, that can affect the size of the ovary as well. So you got to consider because it can make the size of the ovaries bigger if there's a dominant follicle. And so you have to look at the other ultrasound. But that, is neither here nor there. I mean, ideally, I guess it might be better to have this ultrasound in the follicular phase so that you don't encounter that. But, we may do with, what we can get and the schedule. The other thing to note with the ultrasound is much better quality to do transvaginal versus transabdominal. But some of my women, if they have not had previous sexual encounters, prefer not to do the transvaginal, which I totally get. But that can be a limitation that I tell my women about.
Got it. And then, so let's say they have a lot of symptoms that suggest PCOS. You happen to get an ultrasound, even if you don't need it, and it doesn't meet criteria on the ultrasound. Does that rule out PCOS?
No, 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 no. It really doesn't, because there is that 2 out of 3 criteria. But if they only meet 1 out of the 3, and but the ultrasound didn't meet it, then they don't meet criteria. But to qualify for polycystic ovarian syndrome, you really need to meet 2 out of 3 criteria. And we didn't mention this, but you also need to exclude other diagnoses that can look like PCOS. I can't tell you. I mean, I was actually thinking I should write a case series of people who get referred to me for PCOS, and when it is PCOS and when it is not, because a lot of times, when I evaluate for other things, women actually, they don't have PCOS, they have other things. I don't know if you want me to go into some of
Yeah,
these.
yeah. So I think we're supposed to, if they're having irregular periods, especially if there's also signs of androgenic excess, I assume a TSH,
Yes,
prolactin, the 17-hydroxyprogesterone,
yes.
right? And then making sure you're testing for other risk factors of metabolic syndrome, so like A1C lipids.
Mhm.
Am I missing anything?
So, I I always, because I think you probably have experiences like this. Like you remember, oh, I remember when I forgot to do that. And I remember that it was not good that I forgot. Like a long time ago, I remember a woman, she was like, there's no way I'm pregnant. There is no way I'm pregnant. I was like, okay, you said there was no way. And then, she was pregnant. So I always, when I first see them and they haven't had menstrual bleeding in a long time, I always check the pregnancy test. Even when they say they've never had a sexual encounter, I always tell them, like, I totally believe you, but you don't understand. I'm traumatized, so I have to check.
Yeah.
So I always make sure of the pregnancy. I also like to do, if menstrual cycles are happening, I also like to check on the third day of menstrual bleeding, just because hormones change a lot during the cycle. And so I also check FSH, estradiol with that AMH. Now, the reason for checking the FSH and estradiol here is some women with irregular menstrual cycles actually have primary ovarian insufficiency. And I have definitely diagnosed several women coming to me for PCOS with that as well, where the FSH is high and the estradiol is low and AMH is low at that, if they meet that criteria. There are other women who also have hypogonadotropic hypogonadism, where the gonadotropins, both FSH and LH, are low, as well as the estradiol. In women with classic polycystic ovarian syndrome, even though this is not in the criteria, the LH tends to be higher than the FSH. Kind of going back to that pathophysiology where LH secretion is higher. We don't always see that, but we see that. And then the AMH would be higher in women with polycystic ovarian syndrome. And then, you'll never meet an endocrinologist that doesn't check a TSH. And then you mentioned, the prolactin and the 17-hydroxyprogesterone. That one is very important that we check in the follicular phase, because it can increase in the luteal phase after ovulation. So you want to check that in the follicular phase. And I generally do these, again, if I can, on the third day after menstrual bleeding has started and in the morning time. The other thing, it really depends on what you're thinking, is I often also check for hypercortisolism, because Cushing syndrome or Cushing's disease can also present very similarly to PCOS. And so I'm also evaluating that. If the testosterone levels are very high, and I mean usually above 100, but I can also see that range in women with PCOS. If it's above 100, we're also thinking, could they have cancer in the ovary or the adrenal, making extra testosterone? So I mean, that's sort of further down on the line, but or I'm thinking, I hope, as long as I've had good night's sleep, I'm thinking about all of these things. And just to remind me, I do have it listed in my notes so that I don't forget.
Okay, great. And then, so I know you mentioned like day 3 is optimal for the FSH estradiol. So that's also a good time to do the 17 hydroxy progesterone. Does it matter the time of day people obtain any of the labs that you mentioned?
No, but I try to be very consistent because hormones fluctuate so much. So I try to do it during the daytime. For this assessment, it probably doesn't matter as much, but I tend to do it in the morning because, like you said, for women with PCOS, there's not only like these hormonal abnormalities, but PCOS really affects the full gamut. Like I also think it affects, metabolic health. And so I often hear at this time, screen maybe for glucose and the lipid panel. So I'm gonna maybe ask for a fasting, and then maybe we can talk about insulin resistance in a second, but maybe I'll do the insulin. So I'll usually ask for this in an ideal world, day 3 fasting. But as you know, some labs you have to schedule an appointment. So getting someone, when they have their menstrual bleeding, to coordinate the day 3 can sometimes be difficult. But I ask them so that we're always sure, like, when we did it. If I can't get that, I often try to jot down when their last menstrual bleeding was, so that we can interpret the hormones correctly.
Okay, and then you mentioned Cushing's. Would your test of choice be the dexamethasone suppression test, or do you generally do the 24-hour urine test?
So I'll ask you. So this is what I always say to patients. I said you have two options. You could either do a blood test at 8 a.m. after taking dexamethasone the night prior, or collect your urine for 24 hours. What do you think patients were more likely to pick?
Probably the dex. That's
Yes.
when I normally do. Yeah.
You're absolutely correct. But I will sometimes say some women will say, I don't want to take any meds. So then they'll prefer to do the urine. The other thing to note is when you're on estradiol, like on a combined oral contraceptive, the estradiol can affect the cortisol levels, so it can be higher. And so sometimes um, you can get a false positive, like the cortisol is higher than it should be, then we're going to go to the urine test anyways. But, we can start with one. I always say we may still have to do the other. And then I also sometimes check the dexamethasone levels just to make sure they, ingested it correctly. And some medications can also affect the metabolism of dexamethasone.
Okay, and then let's say you're doing all the tests that we've talked about, and because I'm sure I forgot something about my HPA access. Will the dexamethasone affect any of the other tests?
Okay, so that is a very good question. So when I do the cortisol, just so that I'm clean, I tell patients we have to do it on 2 separate days. You can see how popular I am. Depending on how strongly I feel that they have hypercortisolism, I'll do the other stuff first, and then I'll say, okay, let's do this. But if they've already had a lot of the previous testing and they want something, like new, or some patients are very educated and they'll say, I, want to test this, and so then, we'll do that first. I will sometimes give them all the instructions in the world, and I think I did the perfect job with the instructions, and then they'll just do both. Tell me that's happened to you before.
Oh, yes. I write out the dexamethasone suppression test instructions very clearly, but they're either not read or I don't know. It's always wrong.
Yeah.
The time it is wrong, yeah.
Yes.
Okay, great. So it sounds like we're doing a testosterone, free testosterone, if you don't have signs of clinical hyperandrogenism, TSH always, prolactin, 17-hydroxy during the follicular phase, FSH estradiol on day 3 with an AMH.
I
And
also kind of throw in the LH too, since I'm doing natural. Yeah.
Okay, got it. And then a dex suppression test on a separate occasion. Yes.
Exactly.
Okay, great. And then so you mentioned insulin resistance a few times. Is it enough just to get the A1C or fasting glucose when you're evaluating PCOS, or is there any role for the 2-hour glucose tolerance?
Right. Great question. So I because it's my favorite topic, I'm gonna take longer than I'd take for all the other questions. No, I'm just kidding. But because I think the concept of insulin resistance, it's hard to grasp, you know. But just so that we're on the same field, um, insulin's a very important hormone, and one of its main jobs is to help us control our blood sugars, and helps you take up blood sugar into your organs, especially your muscles. But for whatever reason, some people are very insulin sensitive and other people are very insulin resistant. And, we can test this in the lab in humans, do this 3-hour test. And it's really incredible. The degree of insulin sensitivity can vary 4 to 6-fold in people who are otherwise, very healthy. I have been fortunate to participate in a lot of studies. And what we found was that at baseline, your insulin sensitivity is a risk factor for future disease, meaning if you are very insulin resistant, and I, even though I talk about this as something like very dichotomous, the insulin sensitivity, there's a range. There's no like, yes, you're insulin resistant. No, you're insulin sensitive. Because it's a continuous variable. So we just arbitrarily decide like the top third is more insulin resistant, and the bottom third is more insulin sensitive, depending on whatever test you're using. And when you follow people who are insulin resistant, those individuals tend to be at higher risk for a lot of metabolic disorders that we consider age associated, like type 2 diabetes, high blood pressure, dyslipidemia. I mean, there's so many things. Um, I'm going to use this term called fatty liver, but I know that they change the name. They keep changing names for so many things. So it's now considered, metabolic dysfunction associated steatotic liver disease. But so that certain forms of cancers. What we know about insulin resistance in women with polycystic ovarian syndrome is that women with PCOS may be more insulin resistant than their counterparts, accounting for other things that affect insulin resistance. And insulin resistance is genetically determined, but there are lifestyle factors that can make you more insulin resistant. For example, when you gain weight, you become more insulin resistant. When you become more sedentary, you become more insulin resistant. The opposite to that is when you lose weight, we find that individuals become more insulin sensitive. When you're more physically active, you become more insulin sensitive. What's the significance for women with PCOS is that if you have PCOS and you're insulin resistant, it makes your symptoms worse. So going back to the physiology is when you're insulin resistant, your body actually has to make more insulin. And then you're thinking like, oh yeah, it's because you're insulin resistant. But the irony is there are certain organs in your body that retain sensitivity to insulin so that the high insulin is high. Whereas in your muscle to take up glucose, it's like you're resistant, so you need more insulin, but your ovaries see that insulin as high. And so it's driving more testosterone production. Yeah. And so I am very sensitive about weight in my women with polycystic ovarian syndrome because women just, I think their whole life, they have been told certain things about their weight. And, I think it's tough being women in society. It's tough being men too, but I think the messaging for women can be especially tough as related to weight. But I tell my patients, especially, I always say, like, I'm not necessarily focused on your weight, but when you have PCOS, if you gain weight, it makes your symptoms worse. And the reason for that is you become more insulin resistant. And I sort of explain this whole physiology. And so a lot of our therapies can focus on how can we bring down the insulin level for you, which will help your symptoms of PCOS. Like I can't help the pulsatility of your GnRH, but we can do something about the insulin.
Yeah, that's interesting to know that the degree of insulin resistance can kind of vary based on your organ system. I didn't realize that. And so I'm curious that, obviously you talked about how important diet, exercise, being physically active is to help treat insulin resistance. And I know, historically we used a lot of metformin in these patients. And I'm just wondering in patients, let's say who have like pre-diabetes or diabetes, now that we have these better drugs like the GLP-1 agonists, is there like still a role in metformin if let's say you can get coverage for a GLP-1 agonist?
Sure. I mean, that's such a great question. So, when we come, how, we do consultations on patients and at the end, we're deciding on what's the best treatment. Like we have shared decision making. And I say, look, the insulin's important. We want to bring down insulin. So I say, there are 4 things. And so first is, can we get you to the best weight that you can be? And that might include losing weight. And when patients always ask me, they probably ask you too, what weight should I be? And I say, it doesn't have to be some ideal number, but let's focus first on 10% weight loss. Number 2, physical activity. And the bare minimum, I think, especially in a reproductive age population and their age group, is at least 150 minutes of moderate intensity activity. But if you can, I say, it should be double that. And then the third is the diet is also really important. And then, maybe I should put diet first, but the diet, especially if you moderate carbohydrates, can lower insulin levels as well. And I actually realized I didn't answer your question because a lot of people will use glucose to diagnose insulin resistance, but sometimes, um, especially in a young person, if the pancreas is very healthy, you can make a lot of insulin, so the blood sugar is hardly increased at all, but the insulin is what's sky high, and we're not usually measuring insulin, right? So I tell them that the glucose can be a gate, especially, if you have gotten into pre-diabetes territory, and definitely if you've gotten into type 2, but it can be very normal. I have many women with polycystic ovarian syndrome, and I actually like to do the oral glucose tolerance test for two reasons. One is because I like data, but no, I guess that's three reasons. But actually, the real reason is women sometimes, if they're going to have one abnormality, it tends to be the 2-hour glucose. Not the fasting, not the A1C. Obviously, if you already screened for A1C and fasting and they're both elevated, getting 2 hours not going to add, very much. But if those are normal, the 2-hour can be isolated increase. Sometimes we call it impaired glucose tolerance. And then at Stanford, I also order insulin because we have an order set. But it's hard to do at other labs. Where I get the insulin at fasting in 2 hours after, the glucose drink, the 2-hour, the stimulated value can sometimes let me know, like if it's above 100, then, I know, they're more than likely insulin resistant. So I was saying all these to go back to the intervention. So, weight loss, exercise, diet. So the diet, eating moderate carbohydrates, especially lowering the added sugar and processed foods. And then I say medication, and then we review medication options. I absolutely agree with you that the newer medicines, especially what we call the GLP-1 receptor agonists, they've been game changers because they're highly effective to help our patients lose weight. I mean, I used other drugs too before, but these are the most effective. And so I will go to those first if it is very important for patients, especially overweight, obese patients with PCOS. I mean, I definitely have patients with PCOS that are lean, but if in my overweight, obese patients, because the weight, improving insulin sensitivity is so important, I will go to that first. But metformin is commonly considered and used in this situation. I think because, it's sort of easy and, they're relatively inexpensive, right, compared to GLP-1s. And they can bring down insulin. Oh my gosh, I just realized that because I have this form, I just need to have one method. So forgive me, but metformin actually does not improve insulin sensitivity. A lot of people say that. And what I mean by that is when we test it in the lab, because we can measure insulin sensitivity in humans, in individuals who have been taking metformin, it doesn't improve insulin sensitivity the way we measure it. And the way we measure it is, we get a certain level of insulin on board and it's at steady state. We have glucose at infusing at a certain rate. If you're very insulin sensitive, your glucose goes down at that insulin level. Whereas if you're resistant, your glucose stays up. Metformin does not affect how insulin affects glucose uptake in the muscle. However, it does lower insulin. And that's why people always consider metformin being an insulin sensitizer, but it works in a different mechanism. Do you want me to say the mechanism or let it go?
Sure.
Okay. So sorry, I guess this is sort of my pet peeve, and so I'm sorry I'm derailing this conversation, but it can actually lower free fatty acid levels and help clearance of glucose as well as decrease glucose production. But metformin is super interesting because we're always learning new mechanisms of metformin. So I'm sure I could totally be outdated in 1 week. No, I'm just kidding. But it doesn't improve insulin sensitivity, but it can lower insulin. So it can be helpful for women with PCOS. However, it's not going to do as much as probably a GLP-1 in helping women lose weight. It is not even considered a weight loss medication Although, as you know, some people can lose weight with that.
Okay. And then the other aspect I wanted to bring up is, obviously a lot of the treatments for PCOS really differ based on where they are in terms of their family planning. So in if PCOS patients who wants to be pregnant either now or in the future, what are the factors you're considering when you're thinking about if you need to send them to a fertility specialist sooner than the general guideline of trying for 6 or 12 months, depending on if they're over or under 35?
Right, right. So I think that is definitely a topic important to a lot of the women who come to see me. And I work very closely with reproductive endocrinology. So we refer patients back and forth to each other. I think for women with polycystic ovarian syndrome, because fertility can be a challenge, if you've been trying for 6 months, I would say going to see reproductive endocrinology earlier rather than later is always a good idea. And because, as you know, like getting someone referred and seen um, can take some time. I often just say, I just put your name in there already, have the appointment. Um, so I definitely vote for earlier rather than later. And in terms of factors that really matter, I don't know if this is fortunate or unfortunate, but age still is the number one factor. And that's true for all women. Age just is the number one factor. And then if you take age into equation, the other things that matter for women with PCOS that people have evaluated in trials is sort of the degree of symptoms with PCOS, and that can be manifested as the Hirschism score, and then the weight as well. So women who are likely to be most successful getting pregnant with PCOS are the younger, and there's some a cutoff used where it's less than 35, 34. So the younger women who are the leanest, BMI less than 30, and with the lowest sort of PCOS symptom score gauged by Hirschism. So
Hmm.
you would have the highest risk for success if you needed any sort of interventions to get pregnant. The women who tend to have the hardest time are older women, um, the ones that are, over 35, where the BMI is much higher, above 30, 35, and the, PCOS symptom scores are much higher. So that's kind of like the two sort of extremes. But I know, you care about seeing patients with PCOS. So when I see someone for consultation, I always end by saying, if I never see you again, I just want to let you know that if it is important for you to have a family, I want to leave you with this message that it's always good to try earlier rather than later, because sort of age is the number one factor. And then if I have time for more messaging, working on all this lifestyle is way better, years in advance, because you need the time rather than, at the point where, I wanted to have a child yesterday. I want to do, like everything now. And then, we don't have a lot of time at that.
Yeah, yeah, that was interesting, that hirsutism gets kind of factored into how likely someone is to get pregnant. I didn't realize that, and I was curious. I've heard there's certain like racial and ethnic differences and presentations of PCOS, and for example, Asians are less likely to be hirsute than non-Asians. Some Asian populations may have a higher risk of glucose intolerance. I don't know if you could expand on some of those racial ethnic
Yeah,
differences that
sure.
we're aware.
So Asians also, like, people use it as an umbrella term, but as you know, like there are lots of different Asian populations. I'm guessing you and I are East Asians, and East Asians tend to have less hair, especially facial and body hair with PCOS, even at high androgen level. And so there's a scoring system for hair growth, and there's a certain criteria, but it was really developed more in a Caucasian population. And so you need to sort of temper using something like that to assess all individuals for PCOS. I will say sometimes my East Asian women they will literally have one extra hair on the chin, or really not even that much hair growth. Whereas South Asian women may have more hair growth. And so I think, keeping in mind kind of the racial and ethnic differences. The other thing about Hirsutism, I always ask women, like, does it bother you? Is it more than your family members? Because hair growth pattern can also be just very different among groups. And you may not have PCOS, but have more hair than, East Asians, right? And so I think that's important to know. And then you brought up differences in glucose tolerance. I think maybe sort of the underlying things to think about, there could be differences in degree of insulin sensitivity or resistance. And the tricky thing, especially with East Asians, and this comes up a lot, is that our body mass index generally tends to be lower than other populations. And using a reference population of, non-Hispanic whites. But our overall BMI curve is sort of lowered. So gaining any weight or being overweight. So for example, as you know, the lower cut point for BMI for East Asians is 23, also South Asians as well, whereas in other populations, it's 25. And a lot of individuals would consider, if for East Asians, if your BMI is over 25, you could be considered more in the obese category. Some people have used even a little bit higher, but not the 30 cup, like lower than the 30. And so it always seems like disparate where, East Asians, either they're under evaluated because the body mass index is good. So it's possible, like in the US, women of East Asian descent may be underdiagnosed with PCOS because a provider may be thinking, I usually see my PCOS women as more hirsute and overweight, right? But the degree of insulin resistance actually could be the same, but at a lower BMI, if that makes sense. So, if you adjust the BMI, the two groups could be equally insulin resistant. And I think that's what guides risk for glucose tolerance. So if you read something that says, Asians may be more likely to have glucose intolerance or diabetes, it may be using the reference as the Caucasian, where the BMI there is higher. And so you would have thought they would have higher risk, but the Asians had higher risk, but the BMI wasn't quite adjusted. Does that make sense?
Mm-hmm, mm-hmm.
So it's not really about the BMI. I mean, BMI is always a surrogate for what we say excess fat, and it's generally good in a population, but comparing different populations, especially maybe East Asians and another population, I think it falls short if you're using the same kind of standard.
Right, right. All right, and I want to make sure we talk about birth control before we run out of time. So obviously we don't consider in patients that are trying to get pregnant, but for those who have irregular periods, it can help decrease the risk of endometrial cancer. And I guess I have a few questions. Would that help with the hirsutism and the female pattern baldness as well? Would you be okay with them trying a birth control pill first before kind of considering things like aldactone?
Yeah. So when I see my patients with PCOS, I always ask them, like, what bothers you the most? And I would say it is very common, weight gain, irregular menstrual cycles, and hirsutism. If hirsutism, again, especially for the chin, it's your appearance, and as well as the weight. And probably the most effective is to be on some estrogen containing hormones, because estrogen can increase sex hormone binding globulin, which binds the testosterone, so less free testosterone available for action. And there's other mechanisms to sort of lower the testosterone. It's very effective. If hair growth is kind of your number one thing, I will sometimes also add the spironolactone, because it can take up to 6 months
Mm.
to see a difference. And then I say, if this is the most important thing to you, you might also want to consider adding on cosmetic therapy as well. Like, not that it's the kitchen sink, but I would say that you like having all three. But it's costly. It's a time investment. It's more medication. But I would say those three for hair growth. Obviously, it's going to help with irregular menstrual cycles. Um, and I discuss the mechanisms because some women feel, because it's always been thrown at them, that it is the treatment for PCOS, but it's really affecting their symptoms and the regularity of their menstrual cycles. And some women, have side effects or they can't tolerate, birth control. And I wouldn't say there's one clear winner for birth control. I think there are different progestin formulations, and some women respond better to others. Other women just, there's, really no difference. If they can't tolerate a combined oral contraceptives, then we can do sort of progestin only, or if they're not sexually active and they're not looking for birth control, we can do it, every other month or every third month to make sure that they have a withdrawal bleed. Because as you mentioned, women with PCOS they are at higher risk for endometrial cancer. It's not sky high to the point where I don't want anyone to panic, and it's not something we routinely screen for, but we know that having PCOS increases risk for endometrial cancer. And so, birth control or combined oral contraceptives is one way, but you could also do an IUD. You could take progestin, regularly or periodically as well for that purpose.
Okay. And do you feel like most PCOS patients need that endometrial protection? I feel like there's always a lot of hesitancy to start birth control, and let's say they're having periods like every 45 days. They don't
No,
necessarily need to be on anything,
no.
right? Okay.
I think if it's fairly regular, and especially if it's definitely less than, every 60 days, and they don't tend to skip, I'm okay that that is not an absolute thing. So again, going back to, what, what is sort of, most important to you, and what can we do to help those symptoms? You did also, I just want to make sure the female pattern hair loss. Gosh, in my lifetime, I really hope we can offer something better, because that is also very distressing, as you know, to patients. And it's not always related to PCOS. It's not always related to hyperandrogenism. There's a genetic component, but some of these therapies can help a little, but it's very hard. The hair growth is very difficult, and but we'll do the therapies that we mentioned. We might also need like Rogaine topically as well. Anyways,
Hmm. And we talked a little bit about the risk of endometrial cancer and other metabolic conditions that are often seen in PCOS, such as MASLD, hyperlipidemia, hypertension. So I just want to ask you about really like the long-term health risks of PCOS that we should all be aware of.
yeah. So it's so hard to separate. Is is it, what is the independent effect of PCOS or the comorbid, maybe the weight as well, right? Because we know that there are effects of overweight, obesity, and I think that risk is due to insulin resistance. So if you think about, what are the consequences of insulin resistance, we need to think along, those lines. And so, screening for diabetes, dyslipidemia, high blood pressure. Um, and then we talked about the MASLD, and there's actually there's probably a lot more, but the two conditions I find interesting is women with PCOS are at higher risk for sleep apnea, even for their adjusting for weight, and then probably also MASLD. And my theory is, it relates to the testosterone. So that's kind of the extra component that weight alone can't account for. Women who without PCOS who gain weight become more insulin resistant. If we check testosterone levels, they tend to be higher than women who are sensitive without PCOS. But when you have PCOS, the testosterone levels are higher in the insulin sensitive PCOS women versus insulin sensitive controls. But the women with PCOS plus insulin resistance, the testosterone is much higher. So there's sort of this interaction. And I think it's that group that are at particular risk for certain diseases above and beyond sort of the insulin resistance and weight is mast cell D and sleep apnea. Of course, it is common with obesity. It is common with insulin resistance, but I think that extra testosterone sort of enhances the risk. And then you were talking about long term. If you think of women with PCOS as kind of your group with type 2 diabetes, kind of the risk for cardiovascular disease there. And I think after the reproductive age, I think that's sort of the risk that is carried on, and something to sort of think about. And because we see these women early, that's a great time to intervene. But as you know, having patients follow our lifestyle guidelines sometimes is not always the easiest, but I feel like they're a good audience to help their lifelong health.
Thank you so much for having this conversation with me today and bringing more awareness about diagnosing and treating PCOS to both patients and providers. Is there anything else you'd like to highlight?
Thank you so much. I had such a great time today talking to you about PCOS. I just want to let everyone know that even though we've been talking about multiple aspects of PCOS, it really does affect a full spectrum of a woman's life. It affects reproductive health, it affects metabolic health. And we didn't touch on this as much today, but it really affects mental health as well. Women with PCOS have greater rates of depression and anxiety. And I know you and I, even though that's not our specialty, realize that mental health really affects someone's whole health. And I hope in the future we understand better ways to address that as well. And then I guess my last pearl for the day is that remember that menstrual cycle is another vital sign and important to ask in your patients in their reproductive years. Thank you again.
Great. Thank you so much for emphasizing that and making us know that we need to keep in mind that the mental health can be affected in this syndrome. And thank you so much for sharing all your experience and wisdom today.
Thank you.